Okay, perfect. As Nikki mentioned, this is something that's been brought up, a number of times. Concussion recovery obviously is a difficult process, and for people that are in the caregiver role, obviously very difficult for you as well. The way that I've structured this presentation is to first just explain what a concussion is, because part of being able to be a support person is to understand the injury. So as Nikki mentioned, we will be putting this video on YouTube so that it can be viewed and shared by others. Usually the way it works with Zoom is that they'll only be able to see the person talking. So hopefully you won't necessarily show up on any types of screens if you don't want to. But yeah, change your name, turn your camera off, whatever, if you're not comfortable with that thing. And we'll break into it. So today we're going to talk about what a concussion is, what is post-concussion syndrome, and why do some people get it. We'll talk about the experience that some patients have. Obviously, everyone's experience is a little bit different based on the symptoms that they might get. But we'll try to talk in as broad as possible. And then how can you help as a support person, caregiver, loved one, spouse, mother, father, etc. So first, just talking about brain anatomy. This is kind of important because this is how concussions initially occur. The brain has two kind of distinct layers to it. So you can see here on my screen, you have the outer part of the brain, which is called the cortex. This part of the brain is called the gray matter. So it's gray because it's the cell bodies. So if you look at this, this is a brain cell, okay? And you have a cell body, and then you have these long tails called axons. The axons, you can see these little globules along the axon. This is called myelin. This is a kind of a fat layer around, and fat is white. So that's the deeper part of the brain, which is the white matter. So you have the gray matter, which is the cell bodies, and then obviously the alignment of these axons is that the cell bodies are on the outer part, and then you have the axons that go down and connect to other areas of the brain and spinal cord. So that's kind of the makeup of the brain. Why this is important is that a concussion injury is actually from stretching of the brain cells and cross shearing. These two tissue layers are different densities. So the fat layer is a different density than the outer cortical gray matter. And because of those two different tissue densities, when the brain is hit and goes through this acceleration, deceleration, which we'll talk about, you get a pulling apart of these layers because they actually accelerate and decelerate at different rates from each other. So the brain doesn't move uniformly. It's like a big jello glob. And so because of that, it kind of moves around like this. And because those two tissue layers are different densities, they actually pull apart from one another. And that's where you get stretching of these axons, but also the tissue layers kind of shear across each other. And then you're going to get stretching and pulling of those axons as well. Okay. This is kind of what it looks like. So this is just a little GIF here that shows this. So you picture the head getting hit, the brain keeps moving, but you can see kind of that fluid wave that happens in the brain that moves within the skull. So if you picture all these little brain cells that are getting pulled apart as that fluid wave goes through, but also the layers kind of shifting across each other and having that pulling sensation. So that's what happens with a concussion. If we zoom in a little bit and look at this from a cellular level, so this is just a clip of like a motor vehicle accident insurance lawyer actually describing this, but they do a pretty good job of it. But you can see how those two tissue layers, they kind of separate from one another. But here's looking in at the axon. So this is the gray matter, cell body, and then these tails, which is the fat layer, the white matter. They'll show, signal transmission along the axon. And then what you get is this, right? So you get this shearing across, but you also get kind of this, a little bit of a separation between those two layers, which gives a stretch to those brain cells. Okay. They're showing kind of damage to this, but that's actually not what occurs unless the injury is really, really severe. How much force does it take, right? These concussion injuries are not happening with a little bump to the head. And that's something I think that people have a hard time gathering, because sometimes a little bump to the head can provoke concussion-like symptoms, but that's for another reason. If we look at G-forces, which is a measure of acceleration, linear acceleration, concussion happens in adults at around 100 Gs. And the range is anywhere from 70 to 120 in the research. Kids have it a little bit lower. The average is 60 Gs, and the range is between 30 and 90. If we look at all these things, though, if you look at a sneeze, for example, if you sneeze, your brain undergoes about 2.9 Gs. So not enough to give you a concussion. The space shuttle is 3 Gs. High G roller coasters, 3.5 to 6 Gs. So some people will say, oh, I got a concussion by riding on a roller coaster. Well, unless their head hit something very forcefully, this would be very unlikely because the G-force just isn't high enough to actually cause concussion injury. And you can see all these things here. Like, for example, heading a soccer ball, 18 to 23 Gs, well below the range required for concussion injury. So some people will think, well, I got a soccer ball to the head, I have a concussion now. Well, not necessarily, because the G-force is actually quite low. I should mention, though, however, that if you're aware the soccer ball's coming, you kind of stiffen up your neck and you go to meet it. If you're unaware, like soccer ball comes from the side and you don't even know it's coming, boom, hits you in the head, there's going to be more G-forces there, and that can definitely cause concussion injury. So this is in intentional headers. But just to give you a little bit of perspective on this. Mean hit in hockey is around 20 Gs. Mean hit in football at the college and high school levels about 25 Gs. A boxer, this is heavyweight boxers with a all-out punch to the face, is less than concussion threshold. Now, this is on a jab, right? So with a straight jab, you don't necessarily see many boxers get knocked unconscious, and that's because it's below concussion threshold. Anyway, so just kind of showing this, a car accident, your airbags are set to deploy at a change of velocity of about 50 kilometers an hour or 30 miles per hour. So if you're driving down the street at 30 miles an hour and you hit a telephone pole, your airbags are going to go off. That translates to about 60 Gs at the seatbelt, right? So it's quite a significant amount of force that's required to cause the brain to undergo the stretching needed to cause concussion injury. All right, so in adults, around 100 Gs, and in kids, 60. If we think about brain cells as being long tubes, okay, but inside that tube, we have some molecules. So inside of a brain cell, if we look at this tube end on, you have high amounts of potassium inside of the cell. You have high amounts of calcium and sodium outside of the cell. This is all based on concentration gradients. Things want to go where there's less of themselves. Things want to equally distribute. So potassium, because it's high inside the cell and low outside the cell, the natural tendency for potassium is to want to escape the cell. It wants out. Because you have high amounts of calcium and sodium outside of the cell, their tendency is to want to come into the cell where there's less of itself. Okay? So these are concentration gradients. This is how your nervous system works. When a signal comes in to a cell in your brain or in your spinal cord or anything like that, what you're going to get is opening of channels. And when those channels open, potassium goes out, sodium and calcium come in. That changes the composition of the nerve, which makes it excited, and then it fires a signal. So your whole nervous system works in this way. It's just these opening of channels and transmission of ions that changes the composition of a nerve that makes it fire. All right? Your nerves, so your brain cells actually have these little pores on them. So other than these channels that I'm talking about, you actually have these little pores where typically they're so tiny that this stuff can't escape and move around. But with a concussion, you have acceleration of the brain, and when you get that stretching, the pores stretch as well. So when those pores stretch to a significant enough degree, this is when you get an escape. So potassium floods out, sodium and calcium come in because that's their natural tendency. They want to do that. When that happens, you get this firing of neurons. So if you want to think about a normal nervous system, as you sit here and listen to me and see me on camera, all of this is transmitting into electrical signals in your brain because the stimulus is high enough that's causing these channels to open and things to exchange and the nerve to fire, which passes that signal to another neuron deep within your brain that can hear and understand what I'm saying. Okay? With a concussion, this is like an uninhibited electrical storm that happens as a result of that shearing. So there was no signal transmission initially, except for that injury impulse. That injury impulse causes those neurons to stretch, ions to exchange, and then you get this electrical storm where all of your brain cells are now firing simultaneously and in an uninhibited way. So it's an electrical storm that happens within a brain. This can cause somebody to go unconscious, but it doesn't have to. Less than 10% of concussions result in a loss of consciousness. Some people will have blurred vision. Some people will see stars. They'll just see all these speckles in their vision. Some people will have a ringing in their ears. Some people will feel confused or dazed. Some people will be off balance because there's so much activity going on in the brain that they're not able to make sense of the world around them. This is the initial phase of concussion, which is called the excitatory phase. This usually lasts for, a few seconds to a few minutes. It's a very, very short duration thing where you have this electrical storm and then it kind of calms down. Okay? So with a concussion, there's no actual damage to the brain. All it is an electrical storm that happens. Now, because of this electrical storm, there's a lot of, when these compounds exchange, it actually affects the ability for our brain cells to produce energy. And so normally it's produced in our within the structures of the brain cells. It brings in oxygen and other compounds to make a compound called ATP. ATP is the energy molecule which allows our brains to function properly. After this electrical storm, our mitochondria become dysfunctional. So we can't produce the same amount of energy that we could pre-concussion. So what this looks like, this is in an animal. So this is a mouse model. You can see ATP here. This is a group with no concussion. This is 1 minute after concussion, 10 minutes after concussion, 30 minutes after concussion, 2 hours, 6 hours. You can see this little star means that there's a significant difference from the sham. So the sham has no concussion. So this is our baseline kind of energy levels in our brain. But within minutes, we're already starting to see that energy drop because our mitochondrial function is impaired because of the injury. In mice, they hit their peak low 6 hours after injury, and then they gradually start to kind of kick that stuff out of the cell, and the mitochondria starts to recover and starts to spin back up, and we get back to normal eventually. So you can see here at 48 hours, we're still significantly different than the sham, but at 120 hours, which is 5 days, so in a mouse model, recovery is a 5-day process. You have an electrical storm, you have this drop in ATP that gradually recovers over time. So there's no damage to the brain. It's just an energy deficit that's temporary. In humans, it's a little bit longer, but it's the same exact process. So this is a human study, and you can see these black bars here. So this is looking at ATP, okay? So this is a control group. So this is no concussion. So this is our baseline kind of ATP level, this black bar. 3 days after injury, we have a significant difference. 15 days after injury in humans, we're still low on our ATP levels. 22 days after injury, we still have this single star, which represents significant difference. By day 30, that single star has disappeared, which means in an animal model, it's a 5-day process. In humans, it's a between 3 to 4 week process. Some studies show up to maybe 6 weeks. So, but again, there's no physical damage to the brain. This is why when you look at an MRI or a CT scan or anything like that, the brain looks normal. So many people in this group may have had an MRI and some neurologist has told them, yeah, you're fine. But what they don't understand, right, even at that level, they don't understand is that it's just an energy deficit. So it's not going to show up on imaging. Structurally, which is what these images look at, there's no damage to the brain. So there's nothing they can see or point to that suggests there's damage. Now, in more severe brain injuries, like moderate and severe traumatic brain injury, it's the same process where you get this stretching of brain cells, but in this situation, those brain cells can actually rip apart and die. So now you get permanent damage to certain areas of the brain. So when you look at an MRI or a CT scan of somebody with a moderate or severe brain injury, they're likely to have findings of structural brain injury. Concussion and mild traumatic brain injury, which is the classification, by definition, does really not show any pathological damage to the brain. You can have what's called a complicated mild traumatic brain injury, where you may have a slight brain bleed or something like that happens, because when this acceleration happens, you may tear some blood vessels and get a little bit of bleeding in the brain. but it's still in the mild traumatic brain injury because the neurological structures, the brain itself is intact. There's no objective findings of brain injury. Okay. It's just this temporary energy deficit. All right. Now, beyond this period, if you still have symptoms, this is what we call persistent concussion symptoms. So beyond kind of 30 days, by definition, if it's been longer than 4 weeks after your concussion and you're still symptomatic, you now have PCS. It used to be called post-concussion syndrome. The new terminology is persistent concussion symptoms, but it's the same exact thing. The estimates, well, not even the estimates, the literature shows that between 30 to 40% of all concussions end up with PCS. The thinking here and what the research kind of shows is that persistent concussion symptoms are not due to ongoing brain injury because the brain injury has recovered, right? This metabolic difference has recovered. So the symptoms then are due to other things. The symptoms are exactly the same, but they're due to other things. Because when a concussion happens, it also affects a number of different physiologic functions outside of the brain that cause the exact same symptoms as what a concussion would. Okay? So the main drivers of persistent concussion symptoms are, one, dysregulation of the autonomic nervous system. I'm going to go into each of these. So I'll explain each one of them. So I'll just give you a brief synopsis here. Inflammation and dysregulation of the hormone system. So your pituitary, your hypothalamus, and your adrenal system and how they work together. You get issues with the visual system, right? Your eyes don't work as well together. They don't converge as well. They're not able to see peripherally as well. There's a bunch of different things that happen from a visual motor perspective. And also the vestibular system. Some people have influence or damage to the vestibular system with a concussion injury, and that can cause all sorts of dizziness and disequilibrium, trouble navigating the environment, and all that type of stuff. The concussion patient typically thinks of this as brain injury, but it's actually not brain injury. It's an input problem. Your brain is fine, but it's just not getting the right signals. All right, so it's more of a peripheral thing in most cases. Cervical spine is your neck. So if you get a concussion, you're also going to get damage to the neck. Damage to the neck causes the exact same symptoms as concussion. You actually can't separate the two because they're so much the same that concussion and brain and neck injury are literally identical from a symptomatic standpoint. Neck injuries take a lot longer to heal than brain injuries from a mild traumatic brain injury perspective, right? If you have actual damage to the brain in a moderate or severe brain injury, that takes a long time to heal because your nervous system does not repair very well. But with a concussion, there's no damage. It's just this physiologic disruption, this metabolic thing, this low ATP that does recover in a fairly quick time, 3 to 4 weeks. The neck injury, however, can linger on for a long time if it's not addressed properly, and the symptoms are identical. So many patients walking around with post-concussion syndrome are actually dealing with just the neck injury that happened at the same time, but no one's really been able to figure it out. And then finally, mental health. Anxiety, depression, we'll talk about this, increases substantially after concussion injury. And the symptoms of anxiety, depression, post-traumatic stress are also identical to those experienced by concussion. So a lot of times we're dealing with the anxiety of brain injury that's manifesting the same symptoms as brain injury, but in reality, it's actually an anxiety disorder, depression, PTSD. Okay, so all of these 5 things are what drives persistent concussion symptoms. Our goal with this program, for those of you that are outsiders necessarily to the program that may have somebody inside, is to have a systematic approach to addressing each of them. Because we don't know, based on someone's symptom profile or what their current state is, we don't know which one of these is the issue because there's so much overlap. So the way to do this is to address each one of them in a systematic way. Once we address one, we can cross it off the list and we move on to the next one. Because if we can address all of them, then we can get rid of the symptoms. And that's really, I think, what we've been really good at. So first, let's talk about autonomic dysregulation. Your autonomic nervous system is all the things that you don't have to consciously think about. So digestion, heart rate, pupillary constriction and contraction. All of these things are just autonomic. There's two sides to this system. So you have the sympathetic, which is your fight or flight. There's a bear chasing you, and you need to get the hell out of there. So what you're going to get is your pupils will dilate to let more light in, right? Your ears will become more sensitive to pick up more sound. You'll divert blood flow away from your internal organs, and blood flow will go to your working muscles so that you can run. Well, this is going to impact digestion. It's going to impact your breathing rate is going to increase, all of these things. This is kind of our, anxiety state, right? It's fight or flight. The parasympathetic side is also called the rest and digest. This is what now pulls blood away from our working muscles and puts them into our digestive system. We have increased saliva production for eating and digestion. Our gut motility increases where we're able to move food through our system properly. Our pupils are able to constrict and let less light in, and we're able to kind of relax and calm our nervous system down. These two systems work as a teeter-totter. So if sympathetic is up, parasympathetic is down. If parasympathetic is up, sympathetic is down. It kind of just works as this teeter-totter. And they're constantly fluctuating based on what we're doing. With concussion, we end up stuck in our sympathetic dominance, meaning that the sympathetic nervous system is on, meaning that the person is stuck in this fight or flight state, which means that their heart rate is high, their heart rate variability is low, their digestion is poor, they'll get stomach upset, cramping, high heart rate, they'll feel like they're just on edge, right? Their pupils are dilated, so they're letting more light in, so they'll be light sensitive, noise sensitive, all of these things, because their environment doesn't match with where their nervous system thinks it is. It's like their nervous system is constantly sensing danger everywhere, right? A loud noise, a dropping of a pan, bright light, a crowded environment, people walking everywhere. Their nervous system is just on edge. This is going to provoke these types of symptoms. This results in blood flow impairments to the brain. So cognitively, we're not able to think as well. We're not able to exercise because we're not able to get the proper blood flow distribution. We're stuck in this state. Digestive issues, right? Because we've shut off our gut, increased anxiety, sleep problems, right? It's hard to sleep if you're in fight or flight. We need to be able to go to rest and digest to be able to have proper sleep. Hormone imbalances, cognitive problems, etc. So how do we fix it? Well, we need to work on raising the parasympathetic, right? We can't try to drop sympathetic. What we have to do is raise parasympathetic because teeter-totter. So if we can raise our parasympathetic, we will naturally drop our sympathetic and get more of a balance. So the way that we do this is quite obvious when you think about it, right? Stress reduction. So if somebody's under a lot of stress, it's going to be very hard for them to regulate their nervous system. Mindfulness and meditation, right? That's focusing on things like breathing and diaphragmatic activation and focusing on present and not ruminating on things in the future or the past. Being in nature can be quite helpful. Breathing exercises. So I'm going to talk about something called the vagus nerve. The vagus nerve is our parasympathetic nerve, and it's mediated or activated by activation of the diaphragm. So most people, when they're in a sympathetic state, they're very much breathing in their chest, shallow breathing, right? But if we switch that and work on diaphragmatic breathing, big, deep belly breathing, that activates the vagus nerve, which then works to calm the nervous system down. If anyone's ever been in an anxious state, what do? Right? You take that breath, and that's our body's natural way to try and calm things down a little bit. All right. Laughter, right? You're working the diaphragm. You're also forgetting about things. You're focusing on things that are funny and enjoyable for you in the moment. So socializing with friends, laughing, enjoyment, all that stuff works to activate or increase the parasympathetic nervous system. It gets you out of that state of anxiety. Good quality sleep, good diet, and aerobic exercise is the number one thing. Some people aren't there yet. Sometimes if you are very exercise intolerant and you're really out of whack, exercise is hard and you're not there yet. So what we typically do is if somebody can't really exercise at all and they're getting symptoms with even just standing up or even just walking a flight of steps, that means they're probably not ready for the exercise yet. So we start in with these techniques first to get them to a state where they can start implementing exercise. And the evidence on exercise is outstanding. There is so much research to support exercise for concussion. We used to tell people because it's an energy deficit, well, you need to rest, right? Makes sense. We want to do everything to not burn energy, right? Unfortunately, the research has now proven the exact opposite to be true, is that rest actually causes your nervous system to dysregulate even more. So inactivity, bed rest, avoiding light, avoiding noise, avoiding cognitive load actually causes your nervous system to do more of this. It increases your anxiety. It worsens your blood flow. It does all of these things. Exercise, now we actually start exercising within 4 days of injury. So in our program with Complete Concussions, which is a network of about 400 clinics around the world, we now, as soon as someone gets a concussion within the first week, we're putting them on a treadmill and we're having them start to exercise. Just implementing exercise within 4 days of injury drops the rate of post-concussion syndrome by half. So what is 30 to 40%? If we were just to tell people to exercise earlier on in the process, you would actually have only 15 to 20% of people having persistent symptoms. That's just with exercise. And there's other things that you can do as well. The evidence started with PCS. So people that are already symptomatic for months and months and years, we put them on an exercise program and they start to get better, right? So it's no longer rest, it's now moving into exercise. So I think a lot of people that are in this state, right, that are in the concussion fix right now, this is not their fault. This is probably due to medical mismanagement, because still to this day, most doctors, including neurologists that you would expect to have a lot of knowledge around concussion, are still telling their patients that they need to rest. They need to avoid screens. There's no evidence that they should be doing that, really. They need to be in bed. They need to be in a dark room. All of these things. It's well-intentioned because that was the guideline in the early 2000s. It takes 20 years for the research to make it into clinical practice. So these doctors are always going to be 20 years behind unless they're taking a very strong focus on concussion, in which case they would have told you to exercise pretty much right away. So a lot of PCS is actually, in my opinion, due to medical mismanagement because we didn't give people the right instructions up front. And we've put them into this state of PCS now that now we have to undo all this stuff, which is a lot harder to do. If you look at our data, for example, from Complete Concussions, that I mentioned we have 400 clinics that kind of do this stuff. The patients that come to our clinics early on in their recovery within the first week, the chances of them having persistent symptoms is less than 5%. So in the world, it's 30 to 40. At our clinics, just by using an evidence-based approach and doing things early on, it's actually less than 5. So a lot of what I'm saying is this is most people in here have just been completely mismanaged. And that's the unfortunate thing that we're obviously trying to help. Number 2, inflammation and hormones. So inflammation in your brain, if you have an injury to the brain, it's going to cause an inflammatory response. Inflammation in the brain is linked to all sorts of different cognitive problems, but also neurodegenerative diseases like Alzheimer's and things like that are linked to chronic neuroinflammation. It causes fatigue, right? If your brain is inflamed, you're going to feel foggy, fatigued, have low energy levels. It's associated also with mental health, anxiety, depression is a lot related to neuroinflammation. This is mediated by something called the gut-brain axis. And again, it's the vagus nerve. So the vagus nerve is our parasympathetic nerve, which is activated by diaphragm, right? It's our rest and digest. This is kind of how the process works. So you have an injury to the brain. This actually causes the gut. It causes this sympathetic dominance, which causes the gut motility and the way the gut works to shut down. It also causes increased permeability of the gut. So typically our gut has these really tight junctions that doesn't allow a lot of stuff in and out. But with concussion, it opens those junctions up. So now things that shouldn't be getting into our body get into our body. And our body recognizes those things as foreign. So it mounts an immune response to try and attack it. That immune response is inflammation. So basically the injury causes increased gut permeability and reduced gut motility. Now you get inflammation. And it's a cycle. That inflammation goes up to the brain and causes us to be foggy. It keeps our immune response going, which then comes back down to our gut, which causes increased further gut permeability. And the cycle just continues. And we end up just kind of getting worse over time unless we change something. And the way to change it is actually at the gut based on the foods we eat. So you can fix this through the gut. And that's really kind of where we come in with diet and stuff like that. But you can see this dysautonomia. This is the autonomic nervous system piece. So the first two are actually very tightly, intricately related, because that dysautonomia, that sympathetic response, also causes damage to the gut mucosa. It changes the bacterial composition in our gut, right? We have good bacteria and bad bacteria. We actually have a proliferation of bad bacteria within hours after concussion injury. And that just affects things even worse. So then we get inflammation, cytokines, blah, 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 and away we go, right? Cognitive impairment, mood changes, neuroinflammation. So a lot of this is just a chronic inflammatory response that no one has bothered to address. And it just does this and this and this and this. That's why one of the first things we do is we start addressing gut through things like diet, right? So we want to eat healthy. Sugars, processed foods, high carbohydrates, all this stuff feeds bad bacteria. So if you don't change your diet and you're continuing to eat unhealthy, pop, chips, processed food, processed meats, that's just going to make things continue on. Right? So we need to go to a more, whole food diet. We need to go to things that are not processed. We need to eat higher fruits and veg, higher good quality proteins, grass-fed meats, fish, that type of stuff, and get away from anything processed to try and close those gap junctions up and try to influence the gut microbiome, right? Good things like prebiotics, probiotics to help influence that process as well. So this is all stuff that's covered in our modules and lessons around this. Gut dysbiosis, I already talked about. So this is, like I said, dietary interventions, exercise, and sleep all help to regulate this aspect of it. The other side of this is the hormone thing. So the pituitary, the hypothalamus, and the adrenal system, which is your stress hormones, cortisol, adrenaline, all that type of stuff. But what's really impacted are things like sex hormones, progesterone, and estrogen and testosterone, but also growth hormone. And the symptoms of that line up exactly with the symptoms of concussion. So sometimes it's a hormone issue. Sometimes it's a gut issue. Sometimes it's an inflammatory issue. So it's just trying to address all of these things to calm it all down. All right, so that's number 2. Number 3, visual and vestibular system. Your sense of the world around you is based on 3 systems coming together. Your visual system, your vestibular system, but also the muscles and joints of your neck telling you where you are in space. If all 3 of those things are giving you the same information, you will feel good, right? Everything around you is fine. If one of those systems is off, your brain doesn't know how to interpret it. So you feel dizzy in crowded environments, right? It could be a visual problem. It could be a vestibular problem. It could be a neck problem. But one of those things, at least, is giving you different information. So for example, if my eyes are looking and everything seems level from my visual perspective, my ears are sensing that everything is level and normal, but my neck is sending a signal to my brain because it's all tight on one side. It's telling my brain my head is like this. And my brain goes, well, wait a minute. Eyes are telling me this, ears are telling me this, but neck is telling me this. Who do I believe? I don't know who to believe. So I feel weird. And because I feel weird, it's going to throw my autonomic nervous system off. It's going to throw me into kind of fight or flight panic. It senses danger around me because I'm not able to interpret the environment properly. So again, this all just kicks up. It's difficult to parse out which one is the driver. So we address all 3 together. Okay? The treatment for this is rehabilitation. If you go to most, physicians, they'll try to give you some pill for it. The evidence shows that medications for concussion basically don't work because you're trying to address one little piece of it. But most of this from a vestibular standpoint is physical therapy, repositioning neurons, which is physical therapy. There's very few that may require some medication, or if you have a very rare one, you may require some surgical repair. But most of the time, 95% of people are right in this box, and it's a rehab thing. Okay. Rehab doesn't always work though, because if you go to vestibular rehab, and I hear this a lot from members in the program, I've done vestibular, I've done visual, I've done this, but they do it in the wrong way. If you go to a vestibular person, they're very focused on the vestibular system. But like I said, you have to treat all 3. So if they're hyper focused on the vestibular system, but you have an eye issue, it's not going to work for you. If they're hyper focused on the vestibular system and you have a neck issue, it's not going to work for you. So it's important to address all of these. The evidence shows that basically vestibular rehab is less than 50% effective for people with concussion dizziness. So a lot of times you may have gone to a doctor or neurologist that said, and you said, I'm dizzy. And they said, oh, we're going to send you to a vestibular PT. And it didn't work. And it's probably because you have an eye issue or a neck issue that wasn't properly addressed. Okay. So that's why it's a very, you know, um, holistic approach that needs to be taken. Neck dysfunction. Symptoms of the neck, symptoms of concussion are literally identical. You cannot tell them apart. All right. It causes cognitive problems, visual problems, spatial awareness problems, headaches, all the things that a concussion causes, whiplash and neck injury cause as well. The mechanism of injury is also the same. Concussion takes 70 Gs at a minimum in adults. Whiplash injury or damage to the neck only requires 4.5 Gs. So if you've taken 70 Gs to the head, you've taken at least 4.5 to the neck. So literally in 100% of cases of concussion, there is an underlying neck dysfunction or injury. They may not feel neck pain, but they feel headaches and they feel dizziness. That can be due to dysfunction of how the neck is moving and the signals that it's sending to the brain, right? It's not a brain problem. It's an input problem. We have a problem either with our vestibular, with our visual, or our neck. And that's telling our brain all sorts of mixed signals and it doesn't know who to believe. Here's the overlap between concussion and whiplash, right? Headaches, dizziness, cognitive problems, memory, concentration impairments, visual disturbances, fatigue, psychological stress, all can be in either or, okay? This is vision symptoms. So this is purely visual dysfunction. And look at all the research that's been done on this, showing that whiplash and neck dysfunction has the same visual problems as concussion. So a lot of times you have a vision problem, you have trouble navigating your environment, you'll go to a neuro-optometrist. You'll spend all your money on expensive vision rehab, which is important for some people to do. But if you have a neck issue, you're going to spend all your time in vision rehab and get nowhere because the optometrist doesn't understand that the neck can influence the visual system as well. So they're sitting there having you do rehab for gaze stabilizations and convergence insufficiency and all these other things. Meanwhile, you're sitting there with a neck injury, and all this is doing is provoking your symptoms and not actually addressing what needs to be done, which is actually neck treatment. All right, so you may have had this experience. Treatment for neck is usually manual therapy and rehabilitation. You can see in this picture here, this is a patient that I had. This is a few years ago now, but I just had to have this video, so I threw it up. But this patient came in. She was only 3 weeks out. She was very early on. 3 weeks out, still having headaches. So we took her through our process, right? We assessed her exercise tolerance. We put her on the treadmill. She was fine. Exercise was fine for her. We changed her diet. Didn't really make a difference. We checked her visual and vestibular system. No issue. Then we checked her neck. And you just push on some of the muscles of the neck. And based on where someone's headache is, you can figure out where in the neck is causing those symptoms. It's something called referred pain. The way to understand this is something like a heart attack. So when people are having a heart attack, they feel pain where? Left arm, jaw, back, right? There's nothing wrong with your left arm or your jaw, but your brain is not good at picking up where pain is coming from, especially this dull, deep, aching type of constant nagging pain. Your brain just says, something's going on over here and I don't know where. So I'm going to make all this stuff hurt. Well, your neck and your head come from the same system in development. So the overlap between neck pain and head pain is very symbiotic. So when people have neck dysfunction, they'll feel pain in their eye, right? They'll have this headache that's right behind their left eye. Well, the left eye, the referral pattern is from the suboccipital muscles. So you can see here, I'm pushing on her suboccipitals and I say, where do you feel it? And see her face go, oh my God, there it is. And then she traces it. It comes right up to where my headache is. So I do a little bit of soft tissue work on her, adjust the joints of her upper neck. And that was the last time I had to see her. She came back in the next day, all symptoms gone. So in her case, she had a concussion. It had recovered, right? It's over 3 weeks, but she's dealing with residual neck dysfunction. But her only symptom was this headache right here that wasn't going away. So figure it out. Where is it? I trace it back to here, push on that. That caused my headache. I know for a fact now that her headache is coming from that point. I release that tissue, work that out, massage that out, headache goes away, right? Because this head pain is not here. It's actually back here, but she's feeling it here because her brain is not good at picking up where pain comes from, all right? This is rehab for like position and where you are in space, okay? So sometimes your neck like I said, tells you a lot about where you are in space. So this one here, we get people to close their eyes, we get them to turn and then try to come back. And when they think they're in a neutral position, they open their eyes and they see how far off they are of the target, right? He thinks he's in neutral, but he's well below where that target actually is and where he started from. So, and you work on this to try and get them to have better sense of where they are in space. That helps them to interpret their environment around them. All right. So it's manual therapy as well as rehabilitation. Number 5, mental health. Mental health diagnoses in large scale studies increase between 2 to 4 times over people with other types of injuries in the first 3 years after those injuries. So if you compare people with concussion to people with musculoskeletal injuries, so somebody comes in, broken arm, broken leg, whatever, and you compare them, what do they look like after 3 years? Concussion has 2 to 4 times the mental health diagnoses that the people with the other types of injuries have. So the question is there something with concussion that causes mental health diagnosis? We already know that it affects our autonomic nervous system. That's going to increase anxiety. We already know that it affects our gut. Our gut is where our neurotransmitters are produced. If we have altered neurotransmitter production, that's going to cause some mental health complications. So is it due to the injury? Possibly. Or part of it is also probably due to the fact that somebody has ongoing symptoms that they're not getting better, right? It's pretty hard to not be depressed if you've had ongoing symptoms for 3 years. If you've had headaches every single day for 3 years, you're going to be a little bit anxious about why that's still there. If you don't understand what's going on, you're going to feel anxious about that. You're not able to participate in events. You're not able to hang with your friends. You're not able to enjoy your family and go on vacation and do all these things. You're going to feel isolated. So is concussion-related mental health diagnosis, is that due to the injury itself, or is that due to, again, medical mismanagement and improper guidance given to concussion patients that eventually results in this manifestation, right? Chicken or the egg, we don't really know. Mental health conditions also perfectly mimic every single symptom you could possibly have with respect to concussion. I did a presentation last year about cognitive problems, memory difficulties, concentration problems, trouble holding conversation and thoughts and things like that. This is the same thing you see. This is more related to mental health than it is to concussion. And a lot of times it becomes kind of a self-fulfilling prophecy because people believe that concussion results in cognitive problems. They start to manifest the cognitive problems that come with concussion. But yet in tons of research, when we actually test people with persistent concussion symptoms, even though they're claiming to have memory difficulties and all these things, when you actually test them, they test normal. So they actually don't have any cognitive impairment, but they believe that they do. And when you believe that you do, you can see evidence of it everywhere, right? Oh, I forgot my car keys, concussion. Oh, I forgot that somebody told me to pick up, something from the grocery store today and I completely forgot, concussion, right? This is just general kind of forgetfulness that happens throughout life. If I forget to pick up something from the grocery store, I'm like, sorry, I'm an idiot. I was thinking about other things. But the concussion patient immediately attributes that to the concussion injury. And so I think, again, this comes down to education and realizing that your brain is not damaged, but there's other factors at play. Inflammation can cause cognitive problems. Autonomic dysregulation can cause cognitive problems. Mental health can cause cognitive problems. Neck issues can cause cognitive problems. So all of these factors could be the reason why you have cognitive problems. It's not due to brain injury. And I think that I teach people this to try and help. Okay, this isn't a permanent thing. This isn't brain injury. I'm not damaged for life. It's a completely different scenario. It's all of these other factors that can potentially cause the same symptoms. And we just need to figure out what it is. So by reducing anxiety and depression and PTSD and these things, we can actually start to eliminate some of these symptoms. These are barriers to recovery. If somebody is in an anxious state, they're going to be stuck in fight or flight, right? Which is going to affect their gut. And it's a barrier to recovery. So we have to try and address that one almost first. And we do that through things like this, which is education. If we teach people what's going on, potentially we can get them to go, okay, good, that I'm not damaged. This isn't permanent. This isn't lifelong. I feel better about this. Okay. Now, if we know all this and all this evidence is here, and we've kind of put this all together. How come people are where they're at? Well, it comes down to basically a glitch within the medical system. As mentioned, mismanagement. There's tons of research to look at the health education of physicians, and even at the neurology and neurosurgeon level around concussion. Medical school, basically zero on concussion. There was a study that was done in 2012 in Canada, and they found that concussion was not even on the curriculum at all in most Canadian medical schools. They retested that in 2018 and found that now it was about 2 hours, right? 2 hours. So after this session, you people here are going to have more education on concussion than most doctors that are out there. Because remember, this is 2018. So it's only doctors in the past 5 years that you were getting 2 hours. Everyone before that was getting nothing. So most doctors have been practicing since, even 2010, zero education on concussion, or very, very little. So unless they've taken a specific interest in it and treat these patients on a regular basis and follow the research, they're going to be giving you outdated advice. All right. So not covered in medical school, even at the neurology and neurosurgical level. It takes an average 10 to 15 years, and in some cases 20 years for the evidence to actually make it in and permeate into general knowledge, right? Doctors are still using the wives' tales from the 1990s that say that we should just be resting everybody and avoiding screens and all that stuff. There's also an improper care pathway. Most people with concussion will go to the ER or they'll go to the GP. The GP will think, concussion, brain injury, neurologist. I'm going to go to the neurologist. But then when they go to the neurologist, they're ending up with a neurologist that really doesn't know anything about concussion. They give them the wrong information, and then they're left bouncing around in what we call the concussion care maze. So the result here is just delayed recovery because you're not getting the right information when you need it. This is the concussion care maze. People in the concussion fix program will be familiar with this. Picture yourself sitting in a big round room with a bunch of doors. So these are all doors. You don't really know what's behind the door, but one will say vision therapy, one will say, PT, one will say neurology, one will say, hyperbaric oxygen, one will say XYZ. And all you do at a certain point is you're just trying doors. You're just trying to figure out what's going on. All of these require time to make your way down the hallway, and they require money. And you're going to make your way down the hallway only to realize that that particular door is a complete dead end. And then now you're back in the middle of the room being like, all right, I'll try this door. Spend more time, spend more money, get to the end, dead end, nothing there, right? Or I get to this door and I realize there's a lock here. Oh, that's new. There's something I need to unlock, but I need the key. Where's the key? Because things have to be done in the proper order. And so if you're just trying things randomly, you're not going to have that concise kind of program that you're going to need. So it's a lot of trial and error. There's a lack of access to knowledgeable clinicians, as mentioned. The order is important. And the thing that's usually lacking is the foundational elements of care. As mentioned, the main drivers of concussion are these 5 things, or the main drivers of persistent concussion symptoms are these 5 things. Visual, vestibular, and neck issues should actually be done last. But in most scenarios, this is where most people start. And in a lot of cases, they're completely unsuccessful, right? The amount of people that will come to some of our webinars or whatever, and they'll say, oh, but I've been doing all that stuff. Everything you recommend, I've been doing, but I'm still not better. What they don't understand is that they probably haven't just done it in the right order because they don't understand how the things work together, right? Like, for example, I was mentioning autonomic and the gut issue. So even if you changed your diet, if you haven't addressed autonomics, it's just going to keep your gut permeating and the diet's not going to help. So you need to actually address that part first, then the diet. Now it can work. But it's just, again, a lack of education. Mental health should be addressed first. The problem is this is the one that most people ignore because when they go to their doctor, the doctor might say, oh, it's anxiety. And you go, F you, because you think it's not anxiety. There's something physiologically wrong. And doctors are just really bad with their bedside manner as trying to explain this, right? So it's not just anxiety, but anxiety could be playing a role. And if we deny that and we don't actually properly take a look at it and say, maybe it is. Maybe there's something here. I'm going to work now to do everything I can to bring that down. Now you can build on the other things. If you have anxiety in your fight or flight and you go to try and do vision rehab and your nervous system is in this state of like danger, 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 and they're going to put you through the ringer of all sorts of eye exercises, that's going to throw you for a loop. And you're going to end up with a symptomatic setback that's going to last for months. Okay? So it's not that the eye doctor made you worse. It's that you weren't ready to do that yet because your nervous system is still in this state of danger, danger, danger everywhere. So that's the first step. We need to calm that down. As mentioned, the order is important. For those of you that are in the program, you already know this. For those of you that are caregivers, I'm just going to explain this. This is the way that we think about it. Okay. First, we address hyperarousal of the nervous system. We got to calm it down. And we have to address mindset. And if people are stuck in this state of, I have a brain injury, this is permanent, I can't get out of this, they're not in a place where they can start addressing the other concerns. You have to get to a place where the nervous system is now calm, the danger has subsided, you feel safe. Because now, if you try to go up and do rehab, like I mentioned, and you're in this fight or flight, it's just not going to be effective for you at all. So the next step, we address inflammation, gut, hormones, right? Diet, sleep, exercise, all of those foundational elements. Once all of those are working well, now you're ready to take on the rehab. So the first part is the foundation. This is where most people are missing completely, or they've really kind of skimmed it, right? The number one skipped module in our program is the mindset module. People come in, they go, no, that's not me. I don't have an issue there. Boom, 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 skip, skip, skip. And then they go right for the rehab because they think they have an eye issue. So I'm going to go right to vision rehab and see what's going on. We try to get them to take a look at this. You have to think comprehensively. You have to start at the start. You have to do the work. You have to do the steps. If you try to skip ahead, you're just not going to see the benefit. The only way out of this is to literally do the work and do a bottom up kind of approach and do rehab when you're ready for it. Okay. Too early does not help anyone. Okay. PCS experience. It's different for everyone. Some people have constant headaches and pressure in their head. Some people have extreme light and noise sensitivity, right? This could be an autonomic thing. This could be inflammatory. This could be neck related. Some people have mental fogginess, inability to focus or concentrate. Some people have visual motion issues, a lot of trouble with crowds, movement, crowded environments, grocery stores, riding in cars, just any type of visual motion really throws them for a loop. Fatigue, where you can't do anything. You need to have a nap 12 times a day. Exercise intolerance, right? Unable to walk up a flight of steps or do anything without provoking symptoms. And the big kind of, I think, thing that kind of brings is probably pretty universal, I should say, in the post-concussion group, is a lot of people have an extreme fear of doing anything that's going to create a setback or make their condition worse. They already feel like shit, and now we're telling them to go and do things that are probably going to make them feel even more shitty. There's an extreme fear of doing that, which is, again, if we can get the mindset around that, if we can calm the nervous system down, now they can be ready to kind of do things that can provoke symptoms a little bit, but they have the, coping strategies in place to be able to manage, any type of increase in symptoms. So it's a very isolating thing, right? They're afraid to go out with friends, afraid to do anything social because they feel like crap and they don't really know A, what's going on, but B, what's going to provoke them. And that's a scary place to be, right? So as a caregiver, it's very difficult often for you because you want to, get them out. You want to do these things and they're hesitant to do that. So there's a way in which we can build to this. And that's really what I want to get across is that we can get there. And I think that your help is kind of paramount in getting people there. So how can I help or support? I'm going to go into each one of these, but basically, if you want to think about it, in a quick way, validation, participation, avoiding over accommodation, and then also taking care of yourself. Because if you burn out, you're not any help to anybody. All right. Okay. Validation. Acknowledge that it sucks. Okay. Sometimes people just want to vent. And sometimes they need to just talk about how much it sucks. And sometimes you just need to listen and not necessarily try to problem solve. Avoid dismissing the experience or trying to one up them, right? Like, yeah, I'm tired too, right? It's a little bit different. And sometimes that's not going to be helpful to the person who's struggling with this. They want to just vent about how hard this is. And I think that being there and just being like, okay, I understand that this is hard. And then saying, what can I do to help? So avoid trying to problem solve. I mean, me being a man, this is like a natural tendency of us, I think, to just be like, well, okay, well, let's go and do this. Or like, well, if that's the problem, then just remove that and then your problem solved. I've been told that that's not really helpful in many ways. And Melinda sent me this video, so I'm going to share this video. But this is a video called "It's Not About the Nail." So I'm just going to go to here and share this.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
You're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just
Don't.
Try to sneak things my way. All right. I found that hilarious. I had to share that with my wife after. So anyway, it's not about the nail. Instead, try to listen to what they're saying, validate, and ask what they need from you. And sometimes the question is always like, what do you need me to do? Or how can I help? And oftentimes for the concussed patient, that's just one more thing that they have to think about. So instead, try to use more kind of, specific questions like, do you need me to cook dinner tonight? Do you need me to go and get your groceries? Do you need me to do X, Y, Z? And then that's an easier yes or no question, answer. Because if it's, what can I do to help? Now they're trying to think of things you can do to help, and they might not be able to readily acknowledge what that is. Okay. Avoid toxic positivity. So oftentimes, again, all of this stuff is usually meant to be helpful, right? Oh, it could be worse. Look on the bright side. At least this, at least that, right? Again, in the situation, not helpful. Acknowledge this is hard. This is very hard. They're going through probably the most difficult thing in their life. And I always say this, concussion and recovery and going through this process and being diligent and focused and consistent is probably one of the hardest things that people will ever do. Now, they will be much stronger, more resilient people at the end of it. And we often have people at the end of all of this say, I'm actually thankful for my concussion because now it's changed my lifestyle. It's changed my habits. It's made me appreciate these things way more. And they end up being kind of better off for it. But in the time, it's difficult. And so instead, again, like the guy in the video, I'm sorry, that sounds really hard. Yes, that's good. Avoid ableism, right? Well, you look fine. Or you did this last week. Or come on, just push through. You'll be fine, right? Concussion recovery is not linear, right? So this is something people have probably seen quite a bit. But, people think recovery is just going to be like this. But actually what it is just all over the place. I feel good. I feel bad. I feel worse. I feel better. I feel bad. I feel worse. I feel good. And something set me back and I don't know what it is. And now I'm worried about everything I do. And it's a complete mind F throughout the whole process. And that's why, again, building that mental resilience at the start, building up your skills, building up your tolerance is helpful for when these issues arise and you're better able to tackle them then, which is why we really, really harp on people doing that process. Next is participation, especially if you live with the person. One of the most helpful things you can do is start participating in the same things that your loved one is doing. For example, if they have to eat an anti-inflammatory diet and they have to eat a certain way, what would be really, really helpful is for you as a spouse, as a mother, father, family unit to get on board with that and say the whole family's going to eat like this. So that it's not this one individual that like you got everyone else is ordering pizza and they're stuck there with a salad and some carrots. Like having everyone kind of get on board with it, I think is helpful because it just becomes a lifestyle change for the entire family. Exercise, same thing. Meditation, right? If your spouse is having to go and meditate, it would be really helpful for you to say, oh, I'm going to meditate at the same time. That way it's something that is, you're both kind of on the journey together. That can be helpful. And healthy lifestyles are good for everyone, right? So kind of join in that fun. You will feel much better. I promise you that. If you change your diet and start eating healthier, you will notice all sorts of other changes that you had no idea. If you don't live with the person, then it's a little bit different, but you can still be kind of a bit of an accountability buddy where you can check in with them regularly, how they're doing. Hey, how are things going? Great. Keep them somewhat accountable to make sure they're sticking with the plan and the process and the program. Avoid over accommodation. This comes from mostly parent-child relations in the concussion literature. And the first one here is helicopter parents. So what the research shows is parents that are like helicopter parents, people that are overly involved and overly protective in the things that their children do, it's actually associated with worse outcomes for the child. It increases the anxiety of the child, and it increases the stress levels of the child, and actually delays and prolongs recovery. So it's coming from a place of being helpful, but it actually kind of disables. Okay, so avoid, and I'm sure this is the same thing for spousal units and everything else. If you're overly involved and overly protective and trying to basically coddle through this period, it will actually be more disabling in the long run. On a similar vein, parents that are overly accommodative, and overly accommodative means they're adjusting the environment to the child's difficulties. For example, the child has issue with light and noise sensitivities. So parents are keeping all the lights off in the house. They're keeping the volume on the TV down to like a minimum level, right? They're doing everything. Shh, Johnny's needs like to be whatever. Again, that actually makes things worse in the long run for the child. So without intending to, it can lead to enabling behaviors and increases children's stress and negative coping strategies. We meaning avoidance. Kids then tend to avoid things which could provoke symptoms because the family's almost enabling and allowing them to do that. All right. So it's a very kind of fine balance because you don't want to just throw on all the lights and throw the volume on the TV way up and have this crazy noisy environment. But you have to start slow. All right. Start increasing the lights within the house. Start increasing the volume of the TV overall. Start gradually introducing a normal household and environment. Because if you continue to keep things that way, what the nervous system needs is to gradually accommodate to get used to normal things. And if you are, avoiding that or allowing them to avoid that, it's actually kind of disabling. So it's a very fine balance. I don't want people to just go straight 0 to 100, but you have to be willing to gradually move the needle up over time to introduce normal environment. Same thing with things like grocery stores and things like that, right? If you're always doing the shopping because your husband or wife can't, start bringing them along because it's actually good to stimulate them in that way. You're going to come with me today. We're going to go together. When you start having an increase in your symptoms, you just go back to the car and chill. I'll finish. But then the next time we go, let's see how long you lasted and let's try to get you longer. Right? So you're doing things together. They have an out. They can feel safe because there's no risk there because if they get a little bit of symptoms, they can leave. But what you're doing is gradually exposing them to that normal environment. And eventually, they can last the whole time. And then eventually, they can actually go on their own. Right? But you had to kind of build to that point. So do things together, gradually give more responsibilities over time, and let them take ownership of that and start to build their own confidence that they can actually do things. Okay. And the final one I have is take care of yourself. So caring for someone is hard. Acknowledge that. Right. And I think the members need to also consider that it is difficult on your loved ones. I know that you're going through a very difficult time and this is a hard thing for you, but I think understanding and having some empathy for the caregiver and how hard it's been for them because it completely uprooted their life too. I think that understanding is going to be helpful. And I think that if the caregivers can also acknowledge that, yeah, this is hard, right? I have been, doing a lot and this has been a lot and a burden on me. I think that's helpful. If you do burn out, then you're no help to anyone. So you need to take time for yourself, and get rest, get away if you need to, have some alone time, that type of stuff. You need to have that as part of your kind of routine to be able to recharge. This was brought up in the news feed. Actually, somebody mentioned this. They said, I feel like my family has like a cap or a threshold for their availability of sympathy for me. So at some point, and I think a lot of people have felt this, where at a certain point you feel like the family's just been like, hey, come on, let's get over this. Like this has been too much. All right. And obviously it can feel like that as a family member because you're going to hit that breaking point. And I'm hoping this can kind of reset. If you understand the condition a little bit better, you can understand that there is actually a way out, that the people that are in this program right now actually have a bit of a strategy and a process in place that is quite effective. Hopefully we can, reduce that a little bit. Because increased stress, and this is another one from parent-child dynamic, increased stress of the parent leads to worse outcomes for the child. Now you can replace these words and say increased stress for the caregiver probably increases recovery time for the concussed individual. So trying to reduce that household stress, trying to move away from having that cap of your tolerance to be like, I've just had enough. Get it, making sure you have proper breaks, making sure you're getting exercise, making sure you're eating healthy, making sure you're getting enough rest, making sure you have enough time for yourself, I think is all, helpful. So take time for yourself, reduce stress, and have a break. I'll pass it to Melinda because she is our resident psychotherapist. This is more her alley than mine. But I'm glad that she's here. So Melinda, do you want to share anything? And then we can kind of open it up for a little bit of Q&A. We have about 20 minutes for some Q&A.
Thank you, Cam. Yeah, I thought that was a really great overview of sort of the ways that families and support people can lend that helping hand to their important people. The one thing that really stood out about your presentation is that idea of trying to find it's a delicate balance, trying to figure out how to support the people who are suffering in your life with PCS. It is such a challenging experience. And when it's someone you love, a family member, a close friend, you want to do everything you can to support them through their experience. And the funny thing is that we've learned, and what the research now shows us, is that you can help too much and you can support them too much at times. The other side of the coin is that you may not be providing enough help or the right kinds of help. So I think the ways that Cam has sort of demonstrated these two sides can be really helpful just to examine for yourself and say, where might I fit in this picture, and how can I lend a helping hand to the person I love who's experiencing PCS in a way that's going to help them. Oftentimes when we notice certain types of like enabling behaviors, for example, it very rarely and pretty much never is intentional. You don't really know that it's happening because you're doing everything you can to support that person. So when we're thinking about, for example, enabling behaviors, it may be new to you, this sense of, oh, maybe I'm helping too much, or maybe there's things I'm doing that are not supporting them to build their own agency, to help them feel in control of their recovery and healing. And when we're feeling really low and suffering, sometimes we just want someone else to take that load away from us. So this idea of a delicate balance is really resonating, Cam, from what you shared, because it is hard. It's hard to figure out how best to support someone as the individual with PCS. It's really hard to figure out how much help do we need versus how much should I encourage myself to do these things, to build my own resilience, to build my own coping toolbox, to build up my confidence. It can be so tricky. So we always welcome this feedback in the program, and we're happy to chat with you on Thursday Lives and Tuesday Lives. If you're experiencing any of these issues, maybe this is all new to you, so it might be a little bit of digesting that sense of, how do I best support my loved one? Or you may be the individual with PCS that's wondering, what are my support people doing? Do I need to ask for something different? Do I need to be more explicit in what I'm asking for? Sometimes we sort of hope or assume that our loved ones or family members will support us in the way we need, but they may need your help and have you describe to them exactly what your need is. And that can be big too. So maybe we'll open up to questions, Cam, and kind of see how the presentations really resonated for everyone and how we can help further guide based on what they've heard today.
Sure. Yeah. If you want to just raise your hand. So if you go into the bottom of your Zoom, if you're on a desktop, you'll see a button that says reactions. And one of the options is to raise your hand, and maybe we'll just go with raised hands. I can stick around till about 11:30, so 15 minutes. So nobody.
And say, looks like your presentation was so good, you answered all the questions.
Yeah, either that or there was just so much information that people are
Yeah, give everyone a chance to digest.
yeah.
Absolutely.
Yeah.
I know, just to talk about my experience, I found when I went through the program, my husband, even just going on for walks, he wasn't able to join me on my morning walks, but afternoon walks, evening walks, that was the biggest thing for me. And just like you said, the asking specifically what he can do and just doing it. And we kind of went through a list of, these are the things that I typically did, just, naturally we had our own roles in the family. And he knew that that list I couldn't do to the same extent. So he just naturally started doing them. But then he would check in like, hey, do you think you can do this or do you want me to? And those explicit questions, not open-ended, were really, really the big things that helped me that he could do to support me in my recovery. And then just checking in like, hey, did you go in and do the program today? Like legit, did you sign in and go through a lesson? Because again, that was something extremely important for him to just ask me. And then I would feel guilty if I didn't, because then I'm like, okay, I need to do this. Otherwise I'm letting you down also. So those were what I thought was very beneficial for what he did, what he could do when I was going through recovery.
And I think just one thing to kind of note on that, right? We make a list of all the things that I typically do that I can't do right now. And I think the tendency for, patients and caregivers would be like, okay, take the list. I'm going to take that for a while. But then we never add anything back to the person. And I think what you have to do on a regular basis, both as the patient and as the caregiver, is say, okay, every 2 weeks, we're going to add a thing back to your list. And we'll start there. Which one? You let them pick. Which one of these is getting added back every 2 weeks? Because now there's a systematic approach. And it's happening gradually. Because I think the tendency for many people and many family dynamics is spouse will say, okay, here's this list that I'm handling. Now, is there anything you can pick up from here? And patient, out of fear of making things worse, will say, no, I just want to stay where I'm at. And that prevents the growth, and that becomes almost enabling in itself. So I love that idea of taking everything, sitting down, making that list, saying, okay, I'm going to offload this from you, but in 2 weeks, 3 weeks time, 4 weeks time, whatever the timeline is, we are going to sit down again, and I'm going to add one of these things back to you every single 2 week period so that you can gradually build back up to being able to do things. And I think that is an awesome, awesome approach.
Yeah, no, absolutely.
I wonder if it could be both too, right? This idea of, if your loved one with PCS is having a significant fear response or feeling really shut down, and it may need a balance of both encouragement and that validation, like in the not about the nail, because I'm thinking if we just have one without the other, if somebody's experiencing a lot of that sympathetic activation that you talked about, they may just go into shutdown mode and think like, well, I can't do anything. I don't know if I can. And then if we're sort of mapping out something for them that they might not quite be ready for, then they may stay in that shutdown mode. So it goes back to that delicate balance. Well, where is our loved one in this journey? If they're feeling really shut down and paralyzed, maybe even by fear or worry about what might happen, they may stay there if we encourage them too much. That in that instance, it might be best to leave the plan for rehab to the health professionals and stay in a place of validation and empathy with your loved one. However, if they're a little bit further along in their journey and you notice they're maybe capable of doing a little bit more, but they're kind of maybe not sure or they're avoiding it at home, that might be a great time to introduce like a little list, like let's work on this together. Let's really try to make those steps forward. So it can be that really delicate period. Like where is your loved one on that continuum of healing? Because if they're really clammed up and overwhelmed, even if you use encouraging tactics, my guess might be that they'll still feel too overwhelmed to do it, right? They're in that sympathetic state. They need to feel a little bit more balanced to be able to step forward into doing, right? They may need that validation and that empathy. Again, on the flip side, we don't want to stay in validation and empathy forever because they do need to do things.
Right.
So it's this really, really tricky balance that you might just ask yourself and try out a few different things, try empathy and validation and see how that lands. And then try to suggest a few things to encourage them and see how that lands. And depending on how your loved one responds, it might give you a little bit of information around where they're at in that continuum and what their readiness is to sort of start moving forward in their healing.
What do you feel about the idea of like, behavior before, I can't remember what the quote is, but basically it's like if you take somebody who is, suffering, let's say anxiety and depression, just general patient, not necessarily concussion related. And the things that are helpful generally are things like exercise and meditation and doing cognitive behavioral therapy and doing talk therapy and those types of things. And there's tasks that people have to do to kind of lift themselves out of that, to help themselves. But a lot of times you don't feel like doing that, right? So it's like, for example, going on a walk every day. Well, trying to get somebody to actually do that, it's like, okay, if we waited for them to feel like it, you're never going to have it happen. So what's your thinking around like behavior before you're going to want to do it? Because then once you start doing it, then it's like, oh, I realize I can do it. That gives me a little bit of boost of confidence that allows me to continue doing that or realize that I can. And that, sometimes like, even though you don't feel like it, you may need to try and just try it.
Yeah, I mean, if I think maybe we could use an example, anxiety versus depression. So for example, an individual who is clinically depressed or is experiencing a lot of depression is going to need something called behavioral activation. Let's get them moving. Let's get them out. Let's get them not ruminating and not wallowing and not thinking about the things that are keeping them low. So that is an example of when it's helpful for somebody to, a loved one to say, we're going for a walk, let's go. Right? Let's just get out and take 3 deep breaths. Let's move outside. Let's physically move our body. Let's just find a way to get out of the state that you're in. So depression is an example of hypoarousal, right? We're low, we're shut down. Anxiety, on the other hand, can lead to overstimulation. So if we encourage someone too much, too soon to go out and do things, and they're really anxious and fearful, they may go all the way down and start to feel really low. So we want to think about, for individuals who have anxiety, we want to think about really gradual things that they might think about doing. So for example, if somebody just really doesn't feel like they can get out for a walk because they're so fearful about their dizziness and their headaches and their symptoms, you might start by encouraging your loved one to just think about it. Okay, can we just think about or envision in your mind what it would be like just to step outside the house, get that breath of fresh air? What are the things we like about outside? Oftentimes, the things I'm suggesting are also something your health provider would probably be better at. So maybe there's a therapist your loved one is seeing. This isn't all on you, right? You're not responsible to be caring for your loved one in these detailed ways. But in the home, if you're noticing that your loved one is really anxious or even panicked, it can be unhelpful to sort of say, like, let's go, get out, let's get that fresh air, let's move, because they're going to become more shut down, most likely.
Right.
So in that one, it might be, let's think about doing it. Let's envision doing it. Okay, let's write out the things we feel like we can do. What are the things we can do? Let's pick one of those. So it's a little more delicate, a little bit more, how do we build up your existing strengths so that you can do it? And then if we're feeling really, really depressed, you can use the same skills, but sometimes we may need to just mobilize the body when we're really shut down versus overactivated. So it's kind of 2 different skill sets that we want to tap into. Again, this is like clinical and complex and something that your loved one probably would do best with in a therapeutic context. So simplify just for the loved one and support people at home. You might just ask, hey, are you feeling too shut down to go for a walk? What else can we do to help support you? And that might be where those open-ended questions can be helpful versus more direct
Right.
support.
Yeah. Camilla's asking, what
There's-
about if the person is a type A overachiever type personality? I feel that you're mostly covering the other side of the spectrum. Yeah, I think you're right. We probably bias towards the other side, but it's the same kind of thing, but potentially the reverse. So if you want to think about it where somebody is go, 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 doing too much, and then they end up hitting that wall and need and then they're done for like a few weeks, then I think it's both the patient and the care person understanding that, hey, this happens all the time. This is the behavior pattern. You go hard and then you hit that wall. So just reminding them to take breaks, to move slowly, to move methodically, to build the foundational elements, to have that, those kind of strategies in place, and to do things in a very gradual way. Because the example that I use all the time is the tortoise and the hare, right? The tortoise wins the race. The hare that's go, 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 smash, have a nap doesn't win. And in this game, it's the tortoise. You want to be that tortoise. You want to move sometimes painfully slow, especially if you're an overachiever type A that's used to running marathons and doing all this crazy stuff. It's going to be a slow pace for you. And you're going to constantly have to battle with the mindset of, oh my God, I used to be able to do all this stuff. And you're going to try and want to get there really quickly. And that's just not going to be helpful for you. So in those cases, it's almost like you have to kind of take a step back and realize that you will get there. It's just going to take some time. And if you do everything in a very slow, methodical way and gradually build to that, you'll get there. But if you're trying to get there tomorrow, you'll never get there. Right? You need to
Right.
have
And
that tortoise.
maybe that support person then, because I think that's a great question, right? What about the other side of the spectrum? Maybe the support person then is sort of saying, remember, it's okay to take rest days. Remember, it's okay to sort of slow down a bit.
Yes.
Things like that. Pace
The other
yourself.
comment, the other comment here was referencing back to the cliff analogy that you did in a past seminar that we also have up on YouTube, and I think that's great for loved ones to see, to remind themselves too that sometimes we do a little too much. We're at the edge of the cliff and we fall off, and our symptoms spike, but we can climb back up that cliff and still continue working our way away from the cliff. But we fall off the cliff and we get back up, and we fall and we get back up. That linear aspect of recovery, it's not linear.
Yeah.
And then
Yeah,
I'm
people
the
saying,
opposite.
yeah, they overdo it, same thing.
Mhm.
I think that's the confusing thing about recovery from PCS is that it's not linear. There isn't one right answer. It's constantly evolving and shifting. It is really challenging. So it may be reminding yourself as the support person to just slow down and check in. Okay, maybe my person needs something different today. Maybe I need to ask them. Whether it's an open-ended question or something a little bit more directive, you just try it on and see what happens. But just be willing to make changes day to day based on where your person is at and how they're feeling. There are no right answers, but there are some supportive and helpful ways to be there for your person that's living with PCS right now.
I think that's a great spot to end it. Really great presentation. Thank you everyone for coming.